we are going to explain the advantages of DiDi. We have to classify its usage into 3 stages. First is diagnosis, which is the main purpose of DiDi. Then comes the surgery, and then comes the uncovery of any dental implant. So let's talk about the diagnosis. In dentistry, generally people use a ruler or a caliper to measure or make an impression, send it to the lab, and receive the model, because you need an articulated model to be able to measure everything. But with DiDi, you use the patient's mouth as an articulator, and you decide on all the dimensions using all the corners of DiDi. For example, a patient comes with a missing lateral incisor. Let me explain the measurements. This part of the tip is exactly 7 millimeter. 7 in implant dentistry seems to be the magic number. How? Because if you place a 3.5, 3.6, 3.7, 3.8, 3.9, and 4 millimeter implants, these are the average, most probable use of dimensions of dental implants that you're going to place. You require 1.5 millimeter either way. So that makes 4 plus 1.5 and 1.5 is 7. So 7 became the magic number in implant dentistry. Now imagine this patient came with a few missing teeth, say a lateral, a canine, and a molar, for example. Okay? Now imagine the patient wants to know if he can or she can place an implant or not. Generally, you need to make an impression, send it to the lab, get a wax up because it's a front tooth, and so forth, and to check the vertical dimension. If you cannot measure it in the mouth, again, you need an articulated model. Now imagine all that can be done. You take this device in 1 second and you just go through. If it does go in, that means the patient has 7 millimeter. That means you have enough room, means you distally to place an implant. Then you ask the patient to close, and you take your 7 millimeter object, but vertically this time, and you go through. It doesn't go in. That means you cannot place a cementable restoration. Then you go to the other part, which is 5 millimeter, which is the minimum space you need for a screw retained. Because after 4.5 millimeter, it's not possible to give a screw retain. So if 5 millimeter is going in, that means you can place a restorable screw retained restoration in this occlusal vertical dimension. Now imagine even the 5 millimeter doesn't go in. This part of the device is 3 millimeter. So if you are going in and you only have 3 millimeter only, that means you definitely have to increase the vertical dimension or do an orthodontic intrusion or do something, and don't promise the patient an implant when you cannot restore the case. Let's come to another area. Say 2 teeth are missing here. The patient says, I need to restore this area with implants. You say, fine. Generally, you need to calculate. And again, to calculate in the back of the tooth with a ruler is not as easy as, 1 second. It takes time, even if you want to use a caliper. But with this, you have a 14 millimeter object here. You just pass it through in 1 second. If it goes in, that means you have 14 millimeter. Done. You can place 2 implants. Finished. Of course, you can spread it according to the size of your crown, but in 1 second, you are sure, because sometimes there are 2 teeth missing and you think you can place 2 implants because 2 teeth are missing, but it's not 14 millimeters. But you made a 1 millimeter error because you depended on a ruler or on a caliper or on your eyes, and then you trying to place an implant, but you don't have the 3 millimeter inter-implant space, and you don't have the 1.5 millimeter implant tooth space. So for a single one, we just do like that. For 2 implants, we use this part because that's 14. And then for 3 and 4, we also have this part, which is explained again in detail. Now I want to explain a very serious, important, confusing concept, and that is the vertical dimension. Now, this issue is constantly causing a very difficult decision making during the diagnosis. So, why vertical dimension when it's collapsed? Why is it so confusing? Because the theory is you have to keep the patient in a new vertical dimension, which is not collapsed, and wait for 21 days or 45 days till the patient gets used to it. Now, we have a solution for that you don't have to wait even 1 day. And the solution is the material which you are going to place on top of the teeth or make the crown or the veneer. It's either zirconia or Emax ceramic. If the ideal thickness is 1.5 millimeter, so why to make it thicker and why to make it thinner? So, because this tip is 1.5, if I want to increase one arch, I will use the 1.5 millimeter. Of course, I will have two DDs in both sides because I prefer to not push the condyles. I'll keep two DDs. I'll use the 1.5 millimeter. I'll place it in the premolar area, not in the back, not in the front, in the premolar area. And the gap that is created, it's 1.5 millimeter and slightly more in the front and slightly less in the back. And then I will inject interocclusal registration, or we call it bite registration material. And then I'll scan the upper teeth and lower teeth and send that vertical stop to the lab, and they will articulate the model in that 1.5 millimeter open. So they will do the wax up, and we do the entire restoration in 1.5 millimeter open. Now, this will make me not to use a Facebook. So the lab doesn't have to worry about a Facebook. I don't have to worry about a Facebook because I took this inside the mouth, not with an open vertical. And because I know it's only 1.5, till 5 millimeter, there will be no pressure on the condyles in the literature. So 1.5 is safe. Now let's take two jaws. That means the collapse is so much, you need to increase the vertical dimension in both the jaws. Then you go to the 3 millimeter. You place the 3 millimeter. So you need two DDs because you don't want to, because the condyles, if you press on one side, there is a chance that it's not balanced. So you keep the 1.5 millimeter tip in the premolar area of this side and the other side. And then you inject bite registration material in between. And then that's a physical impression. And then you can scan all the teeth and send the physical bite registration to the lab. They will articulate the jaw 1.5 millimeter in centric occlusion. Why? Because you took it in the mouth with the patient closed. So you do not need a Facebook. And the lab doesn't need a Facebook. Why? Because you didn't increase the vertical dimension for the lab to close the vertical dimension in the articulator. You got exactly what you want because the thickness that you want is 1.5, and that's the ideal thickness for either zircon or Emax. So in the posterior area, it will be less, and in the anterior, it will be slightly more, but that's within the limits of the ideal thickness for ceramic materials. Now you might say, I want to do both arches. Then you go to the 3 millimeter, which is this width. So you place one here and the other here, and you ask the patient to bite. And once the patient bites, then you have 3 millimeter open. Of course, the lab has to be familiarized with this concept that they will increase 1.5 millimeter from the maxilla and 1.5 from the mandible. And this way, you have ideal vertical dimension increase, eccentric occlusion sent to the lab. So there is no reason to wait 21 days or 45 days for the patient to get used to this, because this will be always comfortable for the patient. Up to 5 millimeter is a safe distance. We are not going to 5. We are going to 3 maximum and 1.5 minimum. We are not doing it less than 1.5 for any jaw, and we are not doing it more than 3 for both the jaws. So this way, this 1.5 millimeter is an ideal instrument for all the cases that you want to increase the vertical dimension in one jaw, and the 3 millimeter for both the jaws. You might be able to place composite and wax, and then that's also possible. But to get exactly in terms of time, cost, material wise, this is always gives you a constant, same dimension, accurate all the time. That's why we are very much using this on a routine basis.